Hello, thank you for tuning in once again for our online feature presentation here on naturemedicine.ca. Today we'll be continuing on with the initial presentation we've had on Oncotherm. This is the second part in regards to the series that we will have on Oncotherm. Oncotherm is a relatively large subject to tackle, so I figured it'd be best that we could break this down. If not, it would be an extremely long presentation here. So let's jump into it. Again, this is the second part of the series in regards to Oncotherm. So points to consider. Well, in the previous or the first installment of this Oncotherm presentation, we talked about the brief history of Oncotherm. In essence, we were talking about hyperthermia and the distinct differences between hyperthermia and Oncotherm. We briefly touched upon the mechanisms of action. And in today's section, the part two, I really want to focus in on Oncotherm and the utilization with chemotherapy. Other presentations is going to focus in on Oncotherm and the utilization with radiation. I also want to talk about in regards to the utilization of Oncotherm with some of the alternative therapies that we have here at Nature Medicine, such as intravenous vitamin C and turmeric. The utilization of Oncotherm along with low laser light therapy or LLT therapy, the impact that that's going to have, and this is extremely exciting. This is something new, and if I'm not mistaken, I think we are the only ones that are trying to utilize this in addition to the Oncotherm, along with some of our other therapies that we have here. And throughout the whole session, I want to talk about the scheduling. I may even just focus one specific lecture on the scheduling, kind of giving everyone a real life look, so to speak, in regards to some patients that we do have and the scheduling that we have suggested for them in regards to our therapy protocol here. So let's move ahead. As you can see, this is in the previous slides that we've had. This is our Oncotherm. This is the Oncotherm machine. As you can see, it's a bed the patient comes in, lies on, and there is a head that is then therefore situated specifically onto the tumor site. So let's move ahead here. Okay, so Oncotherm. Again, just a little bit in regards to what we've talked about in our first presentation on Oncotherm. It's based on the classical method of hyperthermia, which is high heat. Oncotherm is different. It's modulated electrohyperthermia for oncological use. And it's not used as a sole therapy. Typically, it is combined with chemotherapy, which is what we're going to talk about today, radiation, and other therapies such as intravenous vitamin C. However, it has been used on its own. And again, that is another lecture series or another presentation that I will put online, specifically in regards to the impact of Oncotherm on its own as a sole therapy. Oncotherm is a first and only Class 3 licensed LRHT device approved by Health Canada, which is local regional hyperthermia treatment. It is Health Canada medical device license number is 88986. And the unfortunate thing, it's not FDA approved. So for many of my US patients, they have to travel up here in order to receive this treatment. It is not approved within the United States. At this point in time, to my knowledge, I think there's only one Oncotherm that is being utilized right now in a research-based hospital setting, and the parameters in regards to its use is relatively narrow. What that means, it's specifically used for a specific type of cancer. That's what I've been told. Again, just going through a bit of the background that we touched upon in our first lecture on Oncotherm, hyperthermia, Oncotherm. It's kind of used interchangeably, but there is a big difference. Typically, when you're mentioning hyperthermia, everyone is thinking of the whole body hyperthermia, where the whole body is then therefore heated. Oncotherm utilizes hypothermia, which is the increase of temperature The difference is Oncotherm is more targeted. It targets specifically the cancer cells, where hyperthermia, you're just heating up the whole system. And by doing so, you are invariably also going to be heating up the tumor. Again, Oncotherm is much more targeted. It targets it in such a way due to the unique metabolism of the cancer cell, of the tumor in and of itself. Oncotherm utilizes radio frequency waves at 13.56 megahertz, which is safe. It has no impact on healthy tissues. However, they then therefore start to concentrate specifically on the tumor cells, again, due to the unique metabolism and the cellular makeup of the tumor. It harnesses that radio frequency and thereby heating up, and the healthy cells are not affected whatsoever by this radio frequency. So we're just going through a bit of some of the things that we talked about in the initial presentation. Again, this is a schematic in regards to, as you saw in the first or very first slides of the actual Oncotherm machine. Patient comes in, lies down, and it is a circuit. It is a conductive, if you want to think in that regards. You have the electrode, that mobile head, so to speak, here. And let me see if I can use this. Here we go. So this in and of itself lays on top of the area of that tumor. The radio frequencies are being emitted, positive and negative charges, and positive up here allows for the flow of the radio waves to penetrate through the body, specifically targeting the tumor, and by doing so, heating up the tumor itself. So again, Oncotherm is utilized in combination with chemotherapy, with radiation, with naturopathic alternative IV treatments. And typically it's administered in anywhere from 2 to 3 times a week for 4 to 6 weeks. That would constitute one cycle. And you're looking at trying to get anywhere from 2 to 4 cycles of this. Most of the research, any of the clinical studies that have been done, adhere to this specific frequency. What I've seen in regards to some of those papers, a lot of the impact seems to be around that 2nd to 4th month period, or that 2nd to 4th cycle, with the patients coming in anywhere from 2 to 3 times a week. So how does it work? Mechanisms of actions. Now, we did talk about the Oncotherm and the mechanisms of action briefly. I don't want to get too in depth. I just want everyone to have a better understanding in regards to how it's working. But what we're going to focus in on today is specifically Oncotherm and chemotherapy. Now, there are 3 specific areas of action in regards to Oncotherm and chemotherapy, which is extremely fascinating. First point, it impacts the actual tumor itself to the chemo. That's what Oncotherm does. The second component, it actually enhances the cytotoxicity of the chemo or the chemotherapeutic agent. That could be vitamin C. And again, we'll touch on that on a future presentation. And it also stimulates or enhances the innate immune response. So these are the 3 areas where Oncotherm exerts its action in combination with chemo. Now, that last line in regards to the stimulation of the innate immune response, well, the Oncotherm, regardless of the impact of the chemo, is going to have an impact on the immune system. But I did want to throw that in here in order to then therefore for everyone to understand how chemo and Oncotherm can be working together, and harnessing the benefits of Oncotherm on its own also. However, hopefully I didn't make too many people confused with that last statement, but let's jump into this now. Okay, so let's get into this now. Oncotherm and chemotherapy. So this is the first component and the first point that I want to touch on. Previous slide indicated that Oncotherm has 3 impacts, specifically in combination with chemotherapy. Number 1, it impacts the actual tumor. Number 2, the Oncotherm then therefore increases the cytotoxicity of the chemotherapeutic agent. And number 3, Oncotherm in and of itself and in combination with the chemotherapy can also have an impact on the innate immune system. So let's get to this first point. So how does it work? The mechanisms of actions, chemotherapy, the tumor. So oncothermia sensitizes the tumor to the applied chemotherapy. It increases the vasodilation and localized blood perfusion in the tumor microenvironment, which in turn improves localized drug delivery. So in essence, what it's doing, the actual thermal damage impact to the actual tumor is creating the cells to become more porous. It increases the vascular leakage of the drug into the surrounding microenvironment. And that last point, the constrained thermodynamic transport effects destabilizes the cell membrane. It increases its permeability and structural dysfunction, thereby increasing the absorption rate of the administered chemotherapy agent. That's just a tongue twister of saying, hey, Oncotherm heats up the tumor. By doing so, it disrupts the cellular membrane by allowing, then therefore, the chemotherapeutic agent to leak in. So let's move on. So the mechanism of action, how does it work specifically in regards to chemotherapy? So we talked about in the previous slide the impact of Oncotherm on the specific tumor itself. It's creating the cell walls to become more porous, allowing for the chemotherapeutic agent to seep in. Now this next point is in regards to the impact of Oncotherm and to the actual chemotherapeutic agent itself. And this is the key point. Heat modifies the cytotoxicity of many chemotherapeutic agents. Now, I'll show you in table 1, this is going to be the slide after this, in regards to the chemotherapeutic agents and the impact of heat that it has on the actual agent itself. So the extent of the thermal chemosensitization both in vitro and in vivo can be quantified by the quotient of the clonogenic cell growth or tumor cell growth or tumors treated either with the drug alone or with the same drug at elevated temperatures. That's a long point and it's a tongue twister here. So what this point is, and in order to further on this presentation here, just want to explain this a bit. What this point is in essence stating here with the next slides to show, they're going to be looking in regards to the impact of heat specifically onto the chemotherapeutic agent. But in order to determine the impact that it has, you need to compare it to something. So let's just take, for example, you have a cancer cell line that they're going to be researching, looking on, and you have a chemotherapeutic agent, and we'll call it Agent A. So what they will do is they'll take that cancer cell line, and let's just say there's 100 cancerous cells, and they're going to then therefore utilize chemotherapeutic Agent A specifically on that petri dish of 100 cancer cell lines here. Afterwards, what they will do is they'll wash it off and then they will count the number of remaining cells that are still viable or still alive here. And that will give us a baseline. So as an example, with that first point here, let's say agent A, then therefore afterwards, and it exerts its action, we are left with a 70% kill rate. So the cytotoxicity of that agent A is now established. So now what they're going to do is going to take that same agent and they're going to heat it up. They're going to heat it up to a certain temperature, utilize that same chemotherapeutic agent, which has now been heated, throw it onto that cancer cell line of 100, and then at the end of that, they're going to count how many are still alive. Now let's say after doing this, there is a 75% kill rate. So now they take a look at that same chemotherapeutic agent with no heat. They've increased the heat at a certain temperature. Then they're going to increase the heat at another temperature to see if there's going to be an impact. Now what that's going to do is going to allow us to then therefore establish how heat can impact chemotherapy in itself. And that is what we call the thermal enhancement ratio. So the thermal enhancement ratio, the TER, for certain anti-neoplastic agents at two different temperatures, so two different temperatures were 41.5 and the other one was 43.5, and that's given in table 2, which is going to be followed up in the next few slides here. So the point that's really important for me to make here is look at that temperature difference that they're looking at. So this last point. So now more recent in vivo studies have demonstrated that the thermal enhancement of the cytotoxicities of many chemotherapeutic agents is maximized at temperatures between 40.5 and 43 degrees Celsius here. That's an important component. So we know that within that 40 to 43 degrees Celsius, we can maximize the chemotoxicity, the cytotoxicity of that chemotherapeutic agent. So, hey, you're now looking at the fact that Oncotherm can heat up, disrupt the cellular membrane of the tumor itself, which allows for the entry of the chemotherapeutic agent. Number two, the Oncotherm in and of itself, the heat, can heat up the chemotherapeutic agent, which then renders it that much more toxic so we can kill more. Now, the point is, look at that temperature range. Now, if you remember in the previous presentation that we've talked about on the background of Oncotherm, comparing it to hypothermia and Oncotherm, hypothermia, ubiquitously utilizing it from a perspective that everyone thinks that that is total body hyperthermia. So the total body hyperthermia, remember that one slide that we compared that Oncotherm at 38 degrees had a much more effective kill rate than the total body hyperthermia at 43 degrees? Now that was at 38 degrees Celsius with Oncotherm. Now with Oncotherm, it is reaching anywhere from 40 to 43 degrees. That's the therapeutic range that we're looking at achieving with our patients. So the key component here with this slide is, hey, when patients are coming in and they say, I'm receiving chemotherapy, I was told not to come forward and do any type of complementary therapies because it's going to negate the impact of what I'm doing right now with my oncologist. Well, as you can see here right now with Oncotherm, that is not the case. Oncotherm, if anything, is going to have a positive impact on that chemo. It's going to augment that chemo. So we're going to have that much more of a success rate specifically with that chemo in and of itself in addition to Oncotherm. And that's the whole point that I want to make here. Oncotherm is being utilized in a complementary component here. Oncotherm, again, is being utilized in Europe. It's huge in Asia, and they are done in hospital settings. They're done in oncology clinics. So this is being utilized specifically with the quote-unquote conventional therapies because of the effectiveness of it. And that's the whole point. This is an extremely important point in regards to what we want to try to convey to our patients here. So let's move ahead here. Now this is that table 1. Now I'm going to try to highlight this as best as I can. So all this slide is indicating in regards to, okay, hey, if we take these chemotherapeutic agents here, as you can see, you got platinum drugs here, cisplatin. You got alkylating agents, nitro sources, antibiotics, pyrimidine antagonists, vinca alkaloids, taxanes, and nucleoside analogs right down here. Hopefully it's not too annoying what I'm doing. And then what they're trying to see is what kind of an impact just by heating it up. Okay, so if we go across here with the platinum drugs, cisplatin, oxyplatin, carboplatin, well, it's more than additive. Gradual increase with increasing temperature, and it's highest when it's simultaneous. What does that mean? If they were to receive chemotherapy and concurrently utilizing Oncotherm, you're going to have that much more of an impact. Now, unfortunately, in our situation here, we are not privy to go ahead and administer Oncotherm while they are receiving chemo at the hospital. However, we can, remember, going back to that whole half-life situation, we can get the patient coming in after the chemo is administered, depending how the administration is occurring, if it's in a hospital setting or if it's in an outpatient setting. But the sooner they get in here, as soon as the chemo is done, or some of my patients will actually have the bag of chemo with them in an outpatient setting, we can then therefore, as they are being administered the chemo, administer the Oncotherm. And the impact of that is going to be huge. Alkylating agents right over here, cyclophosphamide, more than additive, again, gradual increase with increasing temperature. Nitro sources here, more than additive, highest when it's simultaneous, antibiotics, doxorubicin, more than additive, it's a bit complex. Only when we can get the temperature greater than 42 degrees Celsius. It's largest when it's simultaneous, less than additive when heat precedes the drug. So what that means is they've done studies and they found out that if they were to do the Oncotherm before and then they were to go in to get the chemotherapeutic, it wasn't as effective as if it were done together or shortly thereafter. Now, the interesting thing is if you take a look as your pyrimidine antagonist and your vinca alkaloids here, right? 5-FU, vincristine, vinblastine, it's independent. There's no interactions there. So, on one sense, a patient's coming in and typically a lot of them will have the bag of the 5-FU, and they're coming in and, they're kind of hesitant because their doctor is saying, hey, look, you don't want to go ahead and do these complementary therapies because they may negate. Well, in essence, Oncotherm is not going to really do much for them. But you also have to realize, and I want to stress, Oncotherm is a component of the many things that we do. It's not the only thing here. Because if we combine this Oncotherm with, say, some of our naturopathic therapeutics, like intravenous vitamin C, well, the intravenous vitamin C is going to be acting as our natural chemotherapeutic agent, and Oncotherm will exert its effect on the vitamin C. So if we're doing that in addition with the 5-FU, we are still going to get positive impacts there. And we'll talk about the impact of vitamin C and Oncotherm in another online presentation. Interesting thing over here is the nucleoside analogs. It's the Paxil, Taxol, and the gemcitabine. It's additive, it's complex, cell type dependent, temperatures anywhere from 41 to 43, which we can easily achieve specifically with the Oncotherm. But look at that last point. Only if it's applied 24 hours before or after the heat. So this is where timing comes into play here. Now, if a patient is receiving the gemcitabine, what I typically will state to them is, okay, let's say you have completed it on the Monday. I don't want you coming in on the Monday to receive the Oncotherm. I want you coming on the Tuesday or the Wednesday. So, and therefore, by doing it in that fashion, you actually get more of a benefit. And that benefit, again, impacting the tumor cells and having a positive benefit on the gemcitabine itself, because it seems that it needs a bit of a 24-hour lag time in between. And in the next or the future presentations, we will again be talking about Oncotherm and radiation. And there's a lot of interesting things there in regards to dosage, as in frequency, how often one should come in, and what we can do to maximize that. And it's quite interesting. One would think doing it every day would be more beneficial, but not necessarily. So again, as you see here, this is that table 1. Now, this next table is the TER, the thermal enhancement ratio, what we talked about, that long point of comparing heat and, at a certain degrees to a specific chemotherapeutic agent. So as you can see, cisplatin, when it was raised to 41.5, the thermal enhancement ratio was at 1.48. Then when it was increased by 2 degrees to 43.5, it increased the thermal enhancement ratio to 1.59, therefore rendering it that much more cytotoxic. And as you can see, everything there except for where we go, 5-FU. 5-FU, doxorubicin, in the previous slide, it indicates really had no impact. So as you can see, it's still at 1, which would be incomparable to if it wasn't heated at all. So that's the thermal enhancement ratio that we talked about. Now, interesting, look at this here. You have this chemotherapeutic agent, and at 30 minutes, the thermal enhancement ratio in comparison to not increasing the temperature was 1.52, so it increased, right? Then if we went ahead and had a duration time of 90 minutes, so 1 hour longer, it tripled. Look at that. It tripled in regards to the thermal enhancement ratio from 3.6. So again, this is just stating the point how Oncotherm can impact the actual chemotherapeutic agent itself. Okay, so now we're coming up to the last point in regards to what Oncotherm, the impact that it has. So the first 2 points, just again to go through. Number 1, Oncotherm is going to be having an impact on the actual tumor itself, rendering it more porous. allowing for the flooding of the chemotherapeutic agent to the area. The second point, what Oncotherm does, it actually also then therefore enhances the cytotoxicity of the actual chemo itself. So now we can deliver it more to that area, and we can deliver something that's more toxic to that area to kill the cancer cells. Now, the third item where Oncotherm renders its impact is on the actual immune system in and of itself. So about 2 slides on this, and then it will be done for this lecture, this online presentation. So at high temperatures, cellular proteins become structurally unstable, and they may even start to unfold, leading to a loss of function. The cells respond to this by producing increasing amount of heat shock proteins. Okay, that's what HSP. It's in regards to them being under stress. So now what happens, the cells start to produce this type of protein. It's a phenomenon referred to as heat shock or heat response. It starts to produce heat shock proteins. Now, some of these heat shock proteins, in particular, heat shock protein 70, are heat inducible. So that means when it starts to get heated up, the cell starts to kind of run into a bit of a panic, and it starts producing this specific protein. And this protein can be released by necrosis. So when the cell starts dying off, and what does chemo do? Chemo is targeting the cancer cells by killing the cancer cells, and by doing so, it creates necrosis. The key thing in regards, as the cancer cells, now we are delivering the chemotherapeutic agent to that area. We're having a much more impact to that actual tumor. Tumors are start to die off, they become necrotic, and they start producing this HSP, heat shock protein 70. When this occurs, this heat shock protein, once outside the cell, once extracellular, they gain potent immunostimulatory functions. So now all of a sudden this starts to get recognized by the immune system, and it stimulates the immune system. So continuing on with that component here, so after a non-lethal heat shock, okay, anywhere from 40 to 43 degrees with the Oncotherm, HSP, heat shock protein 70, was found to be expressed on the surface of malignant cells that became more susceptible to lysis killing by natural killer cells as part of the immune system. So think this through, right? The Oncotherm heats up the tumor. The tumor starts breaking down. More cytotoxic agents are able to penetrate into that area, chemotherapeutic agents. As they start to die off, they're releasing all of these heat shock proteins under stress. These heat shock proteins now all of a sudden get recognized by the immune system. Things such as your natural killer cells that are constantly surveilling the whole area see that, and they go in for the attack. Now, recently, HSP70 activated natural killer cells, NK cells, have been shown to control HSP70 positive primary or metastatic cancer in vivo, or to generate immune responses in patients. So by having this activated, what was happening here is that cancer was contained. It was under control. It wasn't proliferating. The reason being is because the natural killer cells were surveilling around, but it was also impacting other components of the immune system itself. One of the main things that it was impacting the T cell. So this next point, HSP peptide complexes, okay, the proteins released from this dying tumor, the HSP70, or extracted of the tumor cells, are also able to generate an adaptive T cell response. So now the T cells are finding this out. They're seeing these things in regards to these specific protein complexes that are lying around outside on the tumor cells because they've been being destroyed, and by doing so, it then therefore activates or engages the overall innate immune system in and of itself. There is a strong rationale that hyperthermia combined with chemotherapy might also have a positive impact on the host immune system by the potential to induce innate and adaptive immunity. The adaptive immunity specifically is where that T cell comes into play here. So again, this last point is the impact that how the immune system now becomes engaged. We are trying to harness the cytotoxic component of the chemotherapy by impacting the tumor. The tumor in and of itself, as it starts dying off. It's a yard sale. Everything comes flying out. Heat shock proteins are released. By then doing so, it then therefore engages your natural killer cells, which is part of the innate immune system, but it also then therefore starts to stimulate the adaptive immunity where the T cells come into play. Okay, just two more slides here. I know I try to keep it short, but I really want to convey the message, and I'm extremely excited in regards to what Oncotherm can really offer. So this slide here, what did they say? What a picture says 1,000 words. So this slide is in essence just kind of schematically showing what we just talked about in the two previous slides here. So let's see if I can use this. So as you can see here, you have your heat. That's the oncotherm. This is the cancerous cell. The heat in and of itself induces these heat shock proteins to be presented on the surface of that tumor. Your natural killer cell sees that, so it starts to attack that. Then what ends up happening, there's more flooding of this heat shock protein 7. As it does so, it is picked up by what we call antigen presenting cells. That's what APC is. It then therefore presents that to the circulating T cells right here, which see that and creates a response. That's your adaptive response. So this whole slide is in essence an indication how the immune system could feasibly be working in regards to going after the actual cancer itself. So we talked a lot. We talked in regards to the impact in regards to oncotherm and chemotherapy. In the previous, we talked about the brief history. We talked about the mechanism of action. Today's online presentation was specifically with the chemo. Three main points, try to drive that. And I really want to emphasize how oncotherm is utilized with chemo, how it can enhance the effectiveness of chemo. And we're just looking at it from this conventional perspective. Now, what's going to happen when we start introducing some of our components, such as intravenous vitamin C, low laser light therapy? Does that mean 1 + 1 gives us 2, or is 1 + 1 + 1 gives us 10? I mean, the impact of all of this is going to be extremely exciting to see. But just on this terms alone, just on the conventional component here, it has a major impact. So we finished off today with utilization with chemo. We will talk in the next presentation, the utilization with radiation. Looking forward to talk and present with the impact with vitamin C, utilization with LLT or low laser light therapy. And again, throughout this, I may just do a separate component on overall scheduling, and I'll try to sprinkle it in as we do this talk here. But again, I hope you enjoyed today's presentation. I look forward to doing another one, and specific in regards to radiation, and look forward to seeing everyone there.